Hi everybody. Sorry, it's been a crazy time all over the country, but thank you everyone for joining us. This is session number 3 of our talk. For today's session, we're going to talk about communication in the context of pain, and we're very fortunate to have a very experienced palliative care professional. He's none other than Dr. Biju Raghavan, a senior consultant and head of department in Rajaguri Hospital, and he has a vast experience in the field of palliative care, decades now, nearly 1.5 decades and more. He is visiting faculty in several places, including Trivandrum, Hyderabad, Kerala University, Rajagiri Social Sciences, and in his expertise are topics like that we are going to talk about today, which is communication in the context of pain. Now, I'm very fortunate to have known him over the last 2 years in the context of palliative care in Kerala. And we are fortunate to have him as a faculty for these sessions. Thank you, sir. Thank you. And over to you. If there are any questions, please type in the chat box and I'll introduce it as time comes. But we'll try to make it as didactic, discussion based as possible. Over to you, sir. Thank you.
Thank you, Aju, and welcome to all who are joining in. I can see Dr. Ravi Kandan. Hi, sir. How are you? Good to see you over here. And
I'm going to just interrupt, sir. 1 second,
yes.
Biju sir. 1 second.
Yes, yes. Yes,
it will be good if Biju sir can see people's faces. If some of you are comfortable, please switch on the video. It will make it much more better for a speaker to talk that way. Thank you.
Yeah, thank you so much. Anyway, I'm joining in from my mobile, so there's a limit to what I can see. Moreover, there can also be a possibility of the internet getting overloaded. So those who want to join in through video, that is great. And Rajlakshmi, I would be happy if you could help me with sharing the screen, please.
Sure, sir.
Yeah. Sanju Undalla.
Good evening, sir.
Good evening. Good evening. Good to see. All right. Yeah. So I know we have very limited time, and there's a lot of things to cover. So with everybody's permission, let us straight away get on with it. So what are we going to cover today? We are going to touch a little bit about active listening, which is a session in itself. We'll touch a little bit about body language and spoken words. We will be talking about communicating bad news, some of the disclosure models and where it gets into conflict with the patient's rights, and also why we should communicate bad news at all, the rationale behind it. We will touch upon collusion, again a topic in itself, and how we can try to manage collusion before we can even think of communicating bad news. And then coming to the actual standard operating procedure of how to communicate bad news, we'll have a small case study, and we'll also have a role play within the PowerPoint presentation. And last, a few slides on how to manage anger in the clinical setting. I'm not talking about a law and order problem, mob violence, or under the influence of alcohol or substance, our day-to-day dealing with anger in a clinical environment. So feel free to put in your comments and questions in the chat, and Aju will hopefully collate them, and we will discuss them as we go along. So can we have the next slide, please? So body language is a very, very powerful tool in that we have. And just a few things that I want to talk about. Next slide is one is eye contact. You can see in all these pictures, there's a good eye contact happening here. But what about body position? Body position, you see, the best way to interact with a patient is to sit with them. Because even if you're spending 2 minutes, that 2 minutes, if you sit and have a discussion, it gives more satisfaction instead of standing by the bedside of the patient. And when we are sitting, it is best to position ourselves near the foot end of the patient, because then it will be easy to make eye contact. You can see the picture on the left top side. The doctor is standing by the bedside of the patient, and you can see the sternocleidomastoid uh, very clearly. So there, the person has to make a strain to look to make a eye contact. Whereas the doctor who is sitting in the top right side picture is sitting by the foot end of the patient. And if you are going as a big team, it is best that the primary communicator sits in that position and rest of the team blend in the background. You can see some of the other doctors in the background, and you see that the cameraman is behind the patient's field of vision. When it comes to children, it is important that we do not bend at the hip, we bend at the knee so that we can position ourselves at eye level with children. And when it comes to posture, it is best to have a slight bend forward of the spine, a little bit of kyphosis, because it conveys, I am attentive to you, I'm here to listen to you. So just these three things, there are plenty of other things, but just these three things: make eye contact, position yourself so that eye contact is facilitated, and also posture, a little bit of bent forward posture is going to give good results. So if you're going to spend 2 minutes with the patient, sit down and talk to them instead of standing and talking to them. Next slide. A couple of things on the verbal parts. Never assume when people say something, especially in distress, I'm so scared, I'm so worried. Always ask, and then they will tell you what they're scared about, what they're worried about. So this is something that I want to emphasize. Do not assume, because sometimes when we assume, we may be giving a lot of assurance and things like that, but probably we may be totally off track. So just ask, and you will know why they said what they said. Next slide. And there is always scope to give realistic hope, but sometimes we may feel an urge to straightaway give a hope. And please make sure that you are not giving any false hopes. That's the last thing you should be giving anybody. But always give hopes that you can achieve for the patient. There is no situation which is totally hopeless. There is always something to be done. In my practice, many times patients who are sent to me are in a fairly advanced condition, and many times I tell them, see, your disease is fairly advanced, so probably we can't do much about it, but I'll make sure that you do not suffer. I'll make sure that you don't have pain. And when I say this, most of the time the patient and the family members say, oh, that is all that we ever wanted to hear from you, doctor. So it is what I want to emphasize, that there is always some realistic hope to be given. Next slide, please. So coming to breaking bad news, nowadays we don't call it breaking bad news, we call it communicating bad news, because breaking seems like a bit of a violent word. Next slide. So we have a couple of models around the world. One model is non-disclosure model. That is, we do not tell the bad news to the patient. We tell it to the family, but we do not tell it to the patient. We may have reasons for it. Some of these reasons are over there, but this is how we practice. The problem with this model is, next slide, it comes into conflict with a patient who wants to know, because the patient has the right to know. But if we are practicing the model where we do not tell the patient and the patient's right to know comes into conflict with the model we are practicing. Next slide. And if we are practicing a full disclosure model, that is, we tell the patient the full truth, sometimes it can be in conflict with the patient's, next slide, patient's right not to know, because there might be a patient who does not want to know. So if the patient does not want to know, we should not be forcing information on that person. So non-disclosure model, full disclosure model, both have a problem that it may be in conflict with the patient's right, either to know or the right not to know. Next slide, please. So what we need to practice is an individualized disclosure model. Basically, what that means is we have to find out whether the patient in front of you, that individual, whether that person wants to know or does not want to know. And if the person does not want to know, we will not push the information. Whereas if the person wants to know, then we'll have to find out how much the person wants to know and give only that much information, not less, not more, only what the patient wants, the quantity of information that the patient wants. So this is the skill that we will learn as part of the individualized disclosure model. Next slide, please. So before we go on to it, we have to have some clarity of why bad news should be communicated at all. It is such a miserable thing to do. The reason being, there are some positive outcomes out of this. For one, it gives people a chance to close their life's business. It could be related to finance, it could be related to relationships, it could be a bucket list, it could be something spiritual in the form of giving forgiveness or asking forgiveness. It also has a very, very important role in preventing hospital hopping and doctor shopping, because this causes a lot of poverty, this futile search for a treatment that does not exist. When people are staying out of their homes for weeks, months, and all, everything costs money. Even to get a glass of water, you have to pay. As a result, there is no income, there is only expenditure, and many a times people are pushed into poverty. People lose a roof over their head because of hospital hopping and doctor shopping. Only if they knew what the reality was, then they could have reconciled themselves to the reality and then sought what was realistically possible. Next slide, please. Also, an important aspect is barrier to relationship. When the patient has not been told, the family ends up playing a drama in the house, pretending as if everything is normal. And many times they come into our room and then they cry because they can't cry in front of the patient. So, what happens to the value of the relationship? The relationship is kind of artificial, and this is precious time lost, because once the patient dies, you can only wish, if only I could tell the person I love you so much, if only I had a chance to hug the person and cry. So all of these precious moments can happen only now. So it is important that the patient understands this. Only then a strengthening of relationship is possible. So these are broadly three segments of why we should communicate bad news. And I emphasize only to those people who want to know. Next slide. But before we even try to communicate bad news, we know many times the patients will come to our office and say, "Oh, please don't tell it to my patient. We have not told him." Now, this is collusion. This is basically the families trying to enter into a conspiracy of silence with us because they want to protect their loved one. They want to protect their loved one from us. Even though they need our services, they are scared that we may harm their loved one by inadvertently or knowingly conveying the bad news. So please remember that in this situation, we have to focus on the family's distress. Most of the time, we are focusing on the patient's distress. Please focus on the family's distress. They are anxious, they are scared, they are very worried. And agreeing to collude is the first part of reducing their anxiety. You say, okay, fine, no problem, I will not tell the person. And you agree, and also by your behavior you are going to prove that you do not mean any foul play. That is, you are saying, you I will not tell, and behind the family's back you go and tell. That is going to be a disaster. You keep your word, and this will earn you the trust of the family. And then the next big way you can earn the trust of the family is to ensure that the patient is physically comfortable. You take care of the pain, the breathlessness, the restlessness, and the patient is happy, smiling. The family will trust you even more. And now they will listen to you, and then you can convey to them the reason why it is important to communicate bad news, preventing hospital hopping, doctor shopping, finishing the wishes of the patient, and improving the relationship. All these 3 points that we talked about earlier, now you can tell the family, reorient them, and over a period of time, you will see that your conversion rate from collusion to agreeing to communicate bad news, that improves. Please remember, some of the family members may not be amenable to such a suggestion despite your best effort, and that is fine. It is not your agenda to convert everybody. You must try. Trying and failing, there is no shame in it, but not trying, perhaps there's a bit of a shame in it. Next slide, please. So coming to the standard operating procedure of communicating bad news all over the world, we are very familiar with the spikes protocol. Essentially, you set up the interview, and basically, when you say setting up the interview, you have to create the environment. I usually prefer an evening part of the time because by the time the OPA area is usually quiet, and the quiet environment is good for this kind of delicate elective conversations, and also keep a little bit of drinking water and a tissue nearby. So this is what we call as setting, and assess the patient's perception. Basically, we try to understand what does the patient understand is happening to him or her, the insight of the patient. The second part, third part is inviting for a conversation. So we explore whether the patient wants to know or not. And if the patient shows an interest in knowing, only then we proceed to sharing of knowledge in an honest and easy to understand manner. And of course, as a result of it, you can expect an outpouring of emotions and allow emotions to be ventilated. And once the emotions are down, then you can sit and strategize on what can be done, what cannot be done, how we should proceed forward, and take a decision by consensus. So this is in short the spikes protocol, and we will go into a little bit of detail hereafter. Next slide, please. So I'm just giving you a small case medical history. You are all oncologists, so this may seem like a very simplistic story, case, but here the idea is communication, not a real medical case. So Mr. Bharat, 60-year-old gentleman, he had an abdominal discomfort and weight loss of about 2 months duration. He initially went to the local GP, who gave some medications for about a week or so. Didn't work out, so he referred him to the gastroenterologist in the big hospital in the city. There, he underwent a CT abdomen, which showed a mass lesion in the stomach. Thereafter, an endoscopy biopsy showed CA stomach. He was offered surgery, and exploratory lab was done, which showed multiple peritoneal metastasis. Nothing could be done. He was just closed. And thereafter, when he recovered, he was given a reference letter to come and meet you, uh, apparently for supportive care. Now the patient is sitting in front of you. So this is the medical story that is there. And it will take you hardly 2 minutes to read the reference letter and get the story. Now let's listen to what the patient's story. Next slide. So patient says that I had gas, I've been having gas since 2 months. So I went to the nearby doctor. He gave me some gas tablets. There was no relief. Then he asked me to take an X-ray of my stomach. And after taking the X-ray, he gave me a letter to see the gastro doctor in the big city hospital. The gastro doctor did a scan and then also did a tube test. And then after the tube test, they discussed among themselves and they said that a surgery is required. And after the surgery was over, they gave me this letter to come and see you. So this is the patient story. So one is the medical story, and this is the patient story. And there is a third story, and that is the patient's insight. That is what the patient understands. And how do you find the patient's insight? You just dig for more information. Next slide. And this is the insight. I have gas since 2 months. So I went to the nearby doctor. He gave me gas tablets. There was no relief. So he took my X-ray of the stomach. Uh, why did he take the X-ray? I don't know. He asked me to take the X-ray, so I took. And what was the result of the X-ray? Did he tell you what was there in the X-ray? No, I don't know what was there. Okay, then he gave me a letter to see the gastro doctor in the big city hospital. Did your GP tell you why he was referring you to the gastro doctor? Oh, I guess it was for better treatment. Okay, then what happened? The gastro doctor did a scan. Okay, and what was the result of the scan? I don't know. They said something, but I didn't understand. Okay, and then what happened? Then they did a tube test. They put in a tube inside my mouth. What was that for? I don't know what was that for. Okay, and then what was the result of it? They said something, there is some ulcer or something, and that needed surgery. So I don't know what the result was. Okay, then what happened? Then I underwent a surgery there. Okay, and then, well, after surgery my gas problem is gone, but I'm not feeling good at all, I'm tired every day. Okay, then what happened? They gave me this letter to come and see you. Okay, did they tell you why they wanted you to come and meet me? I think for next treatment would be here. So all of these things, when you dig, you will find that patient has a lot of blank spaces. The patient does not know a lot of things. Patient knows a few things, and patient assumes a few things. So that is the difference between the medical story, the patient story, and the patient's insight. Why we need to know the patient's insight? Because we need to understand which are the blank spots in the patient's understanding of the situation. Next slide. So before you get on to the procedure, we have a pre-procedure preparation. You up to date yourself on the situation, and you dedicate time. Remember, communicating bad news is like an elective surgery. You have to have a dedicated time for that, and set the environment like we talked about, and practice active listening skills. That means employing body language and the verbal do's and don'ts, etc. And that we just touched upon little earlier. Next slide. So step one is explore if the patient wants to know. Sometimes the patient themselves may say, Doctor, what is my problem? Can you tell me what is wrong with me? If that is not coming forth, you can explore. You can do an exploratory questioning. Mr. Bharat, you told me you continue to feel tired. Do you wonder why? Do you want to know more about your disease? So this is an exploration. Next slide. Once the patient responds, yes, I do want to know more about my disease, then we have to go to the next step. Next step, slide. Next slide. Next slide. You do not straight away start telling the patient's diagnosis. You first give a warning shot. Warning shot is in two sections. One is if it is something serious, and the second part is would you still want to know? In Malayalam, I would say, കാര്യങ്ങൾ ഇത്തിരി serious ആണെങ്കിലും അറിയണമെന്നുണ്ടോ? In Hindi, I would say, अगर बात कुछ serious है, तो क्या फिर भी आप जानना चाहेंगे? So if it is something serious, would you still want to know? The purpose of warning shot is two. One, straight away, the environment becomes serious. Secondly, it gives the patient a chance to reconsider the decision. Next slide. It's possible that the person, after hearing a warning shot, does not want to proceed. The patient does not make eye contact, may give an excuse. Can you give me my medicines? I'll come after 1 week. Or the person may say, I don't want to know, you tell it to my children, sort of. Well, if you see any of these, that means you should not proceed. Next slide. However, if you have somebody who looks you into your eyes and says, yes, I want to know, then it is pakka. There is no confusion. This person wants to know. Only proceed with somebody like this. So that is the advantage of a warning shot. You get to know who really wants to know and who really does not want to know. Next slide. Once you have differentiated, then you proceed to tell the story of the patient to the patient from the beginning. And as you're telling the story from the beginning, you fill in the blanks with the chunks of information as you go along. And slowly you escalate the information. And whenever the patient stops eye contact, you pause the story. That means patient is perhaps thinking and digesting the new information. And if you have a doubt, you can ask the permission to whether should I proceed or not. If the patient looks up into your eyes and says yes, proceed. If no, perhaps patient had enough. Then you stop there. Next slide. So I'm going to do this as a role play. This is step 3, telling a story. So this is like a role play. Mr. Bharat, you have been suffering from gas since 2 months. Your local doctor gave you some gas medicine. There was no relief. And thereafter, he did the X-ray, right? Next slide. The X-ray showed something like a shadow. And to know more about this shadow, he referred you to the city hospital. See, in the first sentence, it is something like a shadow. And in the next sentence, something like a shadow escalates into shadow. So that is how we are gradually escalating information. Next slide. Oh, I didn't know that. Eye contact is there. Next slide. In the city hospital, the scan showed something like a tumor. And to know what this tumor was, they did the tube test. It is called endoscopy. Next slide. Eye contact still there. We continue the story. Next slide. The tube test was done to see if your tumor was something like a cancer. Next slide. Do you mean to say I have cancer? Next slide. I'm sorry. Yes. Next slide. Remember, now there is no eye contact. So the story takes a pause. Next slide. Next slide. Next slide. Mr. Bharat, do you want to know more? Next slide. They had operated and removed my cancer, didn't they, doctor? Next slide. I'm sorry, when they opened up your tummy, they found the cancer had spread all over. They could not remove it. Next slide. They lied to me. And another possible emotion is, next slide, they lied to me. So remember, whether the person is angry or is crying, both are emotion. And we have to allow emotion to be ventilated. Next slide. And when person is ventilating the emotion, it is important not to do something or say something. It is important to just be with the patient. This is something that we are not very comfortable doing because we are not trained to do it, but just being there till the patient ventilating emotion. It doesn't take long. It doesn't take long. It just takes hardly a minute or two. But being there with the patient, that is very, very crucial at this point of time. Sometimes we have this tendency to pat on the shoulder and say, there, don't worry, we are there with you. None of these words are important. Just being there is important. At best, you can offer a glass of water or move the tissue in front. Don't force the water, don't force the tissue. Just allow the patient to have it if the patient wants to use it. Next slide, please. Now, sometimes the patient may say, how much time do I have, doctor? So this is an alert for you. This is a trick question. Why? Because next slide, you cannot assume why they said what they said. So you ask, why did you say that? Why did you say that? Next slide. And if the patient says, my daughter's marriage is fixed after 6 months, should I arrange to prepone it? That means this patient wants to plan. Whereas another scenario could be, next slide, that how much time do I have, doctor? And then you're asking, next slide, why do you ask that? And then the patient's reaction is, next slide, why did God do this to me? So this is a patient who needs more ventilation. Remember, the question was saying, how much time do I have? And there were two different reasons why people said. One person wanted to plan his daughter's marriage, another person just was ventilating more. So when people say something, they may have a reason, and the reason may be different for different people. So do not assume, always ask why they said what they said. Next slide. So finishing the story, once the emotion is drained out, and then they may ask more information, what can be done, what cannot be done. So be honest and precise with your answer. And if you don't know uh, an answer to a question, for example, why did God do this to me? It's unlikely that many of us may have an answer to that. It is important to just listen to it. There is, because listening is therapeutic, it's not necessary that we always have to do something for them. And as I said before, do not give false hope, give achievable hope. And whatever decision we are taking, it has to be a participatory decision making, taking into view the patient and family's views into what we are proposing. Next slide. So, because we just talked about anger, even within communicating bad news, we can have a position of anger. So, a few slides on anger. Anger is a negative emotion, but it takes a lot of energy to get angry, and it takes even more energy to maintain anger. So the best way of managing anger is to facilitate the flow of the anger without confrontation. So how are we going to go about it? Next slide. To facilitate anger to flow, first we have to consider a couple of body language issues. Remember that when somebody is very angry, there is so much of adrenaline in the body that person may not be able to sit down. So when we see somebody is very angry and then we ask, why don't you sit down? We may make the person even more angry. So when you see somebody who's very angry, standing there in a very aggressive body posture, you also stand up. Because when you stand up, that means you are making your body in equal position to the other person's body. And equality is a positive body language. And then you make eye contact. When you make eye contact, you are showing that you are confident, you are not scared. And confidence is also a positive body language. And then when you're standing, stand with a little bit bent forward, a little bit kyphosis of the spine, which shows that you are respectful towards that person. So you are showing you are equal, confident, and respectful to the person. So there is no confrontation here. So this is the positive body language you can adopt. And the next thing to do is when this person is continuing to get angry, next slide, please. The person is angry and saying things, don't say anything. Just nod your head in agreement, as if you totally agree. I'm sure you will not agree with what they're saying, but it is just a skill. This is just a tool how to get their anger to be ventilated. You nod your head, and then you just listen to what they're saying. And with this, the major part of the severe anger kind of comes down within a very short span of time. But that doesn't mean the total anger is gone away. There is still a lot of anger simmering, but you can see that the person's body relaxes a little bit with what you have done so far. And once you see that, then ask this person, I want to know more about it. Can we sit and talk? So at this point of time, you invite the person to sit and tell you more about the person's grievances. And you sit and let this person talk. You nod your head in agreement. So basically, you are allowing this ventilation of emotion. Now, when you are doing this, it's possible that you may find that there are some genuine things which has aggravated this anger, and you may have some solutions to offer. And if that is the case, please offer the solution. Next slide. It is also possible that there are no solutions to offer because there are been just misunderstanding. Next slide. Can we have the next slide, please? So if that is the situation, then just allowing them to ventilate and letting it go at that should be okay. Only if there is a real indication for an apology, offer an apology. Do not apologize just for the sake of apology because that can also cause irritation. And then once all the anger is subsided, you can shake hands. Nowadays in COVID, we don't shake hands much, but we can leave the situation in a friendly manner. Now, this is what we can practice in our day-to-day anger situations that we face in the clinical environment. I'm not saying this is what we should do when we are dealing with the mob violence, because that is a law and order problem. You cannot practice this in front of patients who are under the influence of alcohol or substance. That is also not possible. This is for our day-to-day anger situation that we can nip in the bud before it becomes too much of a problem. Next slide, please. So coming to the last two slides, the take-home points, something that you can think about. Most important part is body language. You don't have to spend more time than what you would usually spend with your patient when you go for rounds. Only thing that you can change is instead of standing and taking rounds, sit down and take rounds. And when you sit down, see that you are sitting at the foot end of the patient so you can have a direct face-to-face eye contact. In the verbal part of communication, perhaps the most important thing that I would suggest is do not assume. Make the habit of asking why. Why did you say that? So they will tell. So we don't have to assume. When it comes to collusion, we have to understand that apart from the patient, the family is also in a lot of distress. Focusing on the family's distress is important. It's cardinal to managing collusion. Earn their trust, and then they will listen to you. And then you can reorient them. And only with the permission of the family, at least in our context, we should be communicating bad news uh, uh, patient. When it comes to communicating bad news, warning shot is the point where the whole thing changes. From a normal interview, it becomes a serious interview. That is the time where people who are not prepared to hear bad news, they get an option to back out. So warning shot should never be missed. Always give a warning shot. Figure out whether the person sitting in front of you really wants to know. Only then you proceed. And remember, it is not your agenda to give the information to the patient. You are only a facilitator of information. The patient will decide whether they want to know or not. The patient will decide how much they want to know. So your role as a doctor would be a facilitator of information. Next slide. Ventilation of emotion is therapy, whether somebody is ventilating in the form of tears or in the form of angry words. So, allowing ventilation is therapeutic. It is not a waste of your time. It is not a waste of your time. It is a very, very important therapy. Hope. There is no situation where you cannot give realistic hope. There is always some realistic hope you can give, but never give false hopes. And when it comes to dealing with anger, you are definitely smarter than taking it personally. You manipulate the psyche of the person who is getting angry with your body language skills and allow non confrontational ventilation of anger. It is an easy skill to master. And these are the take home points that I want to finish with. I'll be happy to take questions, whether in the form of chat or if anybody wants to um, have
Thank you,
a
Dr.
video,
Biju.
right?
Thank you.
About.
Thank you. Dr. Dodala Mahadev, can you discuss your question or your comment?
Are
Yeah,
you able to hear?
please. Yes, I can hear you.
Yeah. Many times patients comes in advanced stage from other centers. So what to tell them? How to sympathize with the patient?
I'm not sure whether I'm not sure I understood the
Yeah,
question.
I will explain, Dr. Biju, because he has written that in chat box. So, for example, even today, I had a patient who underwent surgery when radiation and chemotherapy should have been ideal for a rectal cancer patient before surgery. So it was frustrating, that the patient underwent surgery first when better standard of care would have been to give neoadjuvant chemotherapy and radiation. Such cases, when you see patients who are referred from other places and you know that some mistakes have been done or some errors have been done, he is asking, you want to apologize for others' mistake, or even in communication. So other people may have said you don't have cancer, or may have hid things, or may have given false hopes. Should you, as a doctor who is seeing the patient now, say sorry, and how do you handle that kind of issue?
Or delay in diagnosis?
Or delay in diagnosis, yeah. When
There,
let's say
many,
some patient presents as piles for rectal
yeah.
cancer and gets delayed and delayed because some other doctor said it's piles. I mean, if
Or
it's an
key,
alternative medicine doctor, we can always dump on them.
or maybe lung cancer. They treat for tuberculosis for many months.
All right. So a couple of points. One, medical science is not an exact science like mathematics, and as a result, there are multiple variables. So if your colleague misdiagnosed something, uh, or they had a thought process and they said, okay, we should have a surgery first, that's fine. it is something that you can discuss with your colleagues in a separate platform. But when it comes to interacting with their patients and their families and society at large, never badmouth your colleagues, because it only creates negativity among us. I'm not saying that we are going to protect criminals among us. No, there can be genuine differences of opinion on how to evaluate. There can be genuine difference of opinion on how to manage. There can be mistakes. So that none of that should be a reason to uh, bring those topics in front of patient and family, for the simple fact that medical uh, decision making and management is much complex than how we can put it in front of uh, lay public. We definitely must have a robust discussion with our colleagues uh, on our difference of opinion with whatever it is. A united front among healthcare professionals with the community is very important, because when you show that you respect your colleagues, you praise your colleagues, it creates a sense of trust within the society that, yeah, the doctors are competent, doctors are good. When you badmouth, it creates distrust within the society, and they don't know whom to believe. And I can assure you, if somebody hears that you badmouthed them, it can be guaranteed that they will end up badmouthing you. And then we will all end up badmouthing each other. And then the community, the society will be very confused whom to believe. So it is best that we do not badmouth each other. And no need to apologize for the decisions of another of your colleague, your brother in medicine.
Doctor,
Does that kind of answer what you were looking for?
Okay.
it's a tough question, a lot of tough questions for the topic that you're discussing today. Dr. Sunil Kaushik, can you ask the question that you have?
Hello, good evening, sir.
Good evening.
Hello, am I audible?
Yes, you are. You're audible. Yes, you
Yes,
are
you are.
audible.
Yes, you are.
So how do we communicate in minors, young patients, children? Do we communicate in the same manner?
No, definitely it has to be age appropriate. How you communicate with uh, a toddler, how you communicate with adolescent would be vastly different. And because uh, the children's perception of reality would also vary according to their age. So what you are trying to convey has to be age appropriate.
So, in terms of pain management, have you consistently noticed in your practice that good communication and patient physician rapport has an impact in modulating pain?
Absolutely, absolutely. There have been this study in the Journal of Neurology. It's quite old study, 1986, I think, where they found that the best indicator of an outcome of headache was the patient's perception that they have been listened to properly by their treating doctor in the first visit itself. So this having been listened to has a clinical outcome impact. So definitely, I agree that we have to give them the sense of having been listened to. The advantage of communication skills is that it saves you time, energy, and effort. Sometimes people think that communication means spending more time. I'm saying communication should save you time, energy, and effort, and maximize your clinical output. So we have ways and means of making the patients feel better by our body language, making them feel that they have listened to without us spending extra time with them. So that was just some of the things I mentioned earlier. One example being sitting down and talking to them. When it comes to pain, uh, many times we have this problem that there are some uh, misperceptions about pain and pain management, pain medicines among vast sections of society. For example, many people believe that it is okay to tolerate pain, not knowing that every time you're experiencing pain, you're having a stress response. And as a result, you have a lot of stress hormones floating around in your body, which has a negative impact in every system of your body. If you have persistent pain, you have reflex vasoconstriction, and that will reduce your perfusion. And for a post operative patient in pain, you have delayed healing. So there are multiple aspects to pain that we don't talk about. So thinking that tolerating pain is okay is like a diabetic saying that I have high blood sugar, I will tolerate it. So we all know that high blood sugar will definitely damage our systems, our kidneys, and everything. Similarly, tolerating pain has a lot of detrimental effect on multiple systems, metabolism, endocrinology, immunity, whole sort of detrimental effects are there. Another misconception is that if you take pain medicine, it is going to damage your kidney. Now, we have to understand there are pain medicines in different categories, and it is the judicious use of it that has to be promoted. And I don't think there'll be much of a problem among this bunch of oncologists, but non-oncology doctors are mortally afraid of morphine. We know that morphine is such a beautiful drug. It does not harm your kidneys, it does not harm your liver, it does not cause ulcers. There is no upper limit to the use of morphine. You can control most types of pain with morphine. You can give it for long term, for long term use. So, and it is very cheap. What 10 mg tablet costs 1 rupee 30 paise. So it can be used for people who are on dialysis. It can be used for people who have end stage liver failure. So it is, and it can be used for non-pain purposes, for refractory breathlessness, for refractory cough. So it is something that can be really useful. But apart from, mostly the oncologists are more familiar with the use of morphine. But if you look at the other specialists, they are mortally afraid of morphine. And this translates into some of the instructions that they give to the patients and family. And as a result, a word goes out that morphine is something that is to be given, it's something that you give for dying patients. So that is not true at all. So a lot of misconceptions. We need to use communication skills to clarify. A major part of my pain management strategy is communicating, and unfortunately, we have to fight very hard to reach pain relief to the patient.
Sir, you talked about spikes protocol and it requires time, a good setting. Sometimes in busy OP clinic, I have 20 patients waiting and a third patient would require a lot of my time to break bad news. Is it okay in that setting to send them out for a lab test or an X-ray so I can delay them for the last patient of the day and I have time and a good frame of mind to talk about their issue rather than just rushing into it quickly. That's one thing. Number two is about proxy. I see a lot of patients. I don't see patients, but family members coming as proxy. Um, they expect everything to be informed. They won't let you talk to the patient. Nothing. They just these are patients who are doctor shopping. End of life doctor shopping patients. So challenging situation. I don't know if you have an answer for that, but your thoughts on it. First one is about delaying the discussion doing some unethical or shadowy means to delay it deliberately so you can get more time to discuss. Second is about proxy discussions.
Right. So first thing first, uh, uh, communicating bad news is a elective communication procedure. It is like you trying to do a cholecystectomy. You need to dedicate time for it, right? You can't do it on the run. Now, sending them for a lab or sending them for a meal or just telling them I need to talk to you in detail, but right now I'm busy, can you come back at let's say 5:30 or 6? Will that be possible? Maybe that could be an option you could think of. If you don't want to do a lab test just for the heck of it, just to get time a slot, instead of that you can tell them that I need to discuss something very important with you, but right now I'm little busy. I'm available at 6 o'clock. Is that okay? Or is tomorrow 6 o'clock okay? So it is basically you can have a very simple honest conversation and fix a time. That is point number one. I don't know whether that helps or not. That
So
was
that
my
is
take
helpful.
on it.
That is helpful.
The second part is a lot of family members coming and trying to discuss and things like that. Yeah. So how I deal with that is I have done away with the two family members coming and talking to me spending half an hour. Next day, two other family members coming and talking to me, and me spending another half an hour. I don't have time like that. So basically, when I have a situation where the family wants to have a discussion with me, I tell them, I have some important things to talk to you, but I want all people who are concerned with this person, Mr. Bharat, whoever is concerned about this person, can you all come and meet me tomorrow at evening 5:36, something like that. Now, advantage of that is that we get all the people concerned with this patient together at the same time. If not everybody, at least a major chunk of people. So nobody feels left out. Many times what happens is somebody important in the family hierarchy is not called in, and that person's ego is poked. And as a result, that person will create problems just for the heck of creating problems. So we have all people together, and whatever we are discussing, everybody is hearing at the same time. So everybody is on the same page. And if somebody has some questions or concerns, that gets discussed at the same time, and we may come up with a solution based on the discussion. Many times I just have to sit there and facilitate. I They do the hard work. I just facilitate, and some sort of kind of acceptable solution comes out. So there might be different opinions within the family. I just facilitate. It's like an anchor of a TV show. And then they talk out between them. So sometimes there may be heated exchanges, but kind of facilitate. And I just sit back and relax. A lot of my work is taken care of by that. So at the end of it, everybody had a say. Everybody knows what the situation is like, and everybody is agreement on is on agreement on how we should proceed. So that is how I would manage a family discussion, especially if there is conflict involved.
Doc, we have time for two questions. One question is already raised. I would like Dr. Manjunath, if he can kindly discuss it audio wise.
Hello, am I audible, sir?
Yes, you are. Yes, you
Sir, I had a patient with a CS stomach. She was a nun, a very religious person. She was into meditation and spirituality, but she had a lot of pain. But the patient was persistently refusing to take anything more than one or two simple tablets. She was not ready to take morphine. She was not ready for any other type of pain management. Patient, I mean, I got an impression that patient knew what she was talking about. She said she can manage it with spiritual meditation and prayer. And ultimately, I had to kind of agree to her because I got a sense that she understands what she's talking about, and I couldn't convince her. And recently, she passed away. They told me that she was calm when she died. Uh, was what I did, was it okay, or could I have done anything different or better? I just want to know.
Yeah, I think you did the best that was possible. I think you did what was right. Please understand that as doctors, we are facilitators of healing. We are facilitators of caring. We are facilitators of comfort. It cannot be our agenda. I mean, it is not that there is some kind of agenda on top of our head that we have to get it done against the wishes of the patient. What is in our hand is to, first of all, gain knowledge and the skill, and then convey to our patient and their families that this is the situation and this is what is possible. Patients have the right to refuse your treatment because ultimately it is their body, it is their life. They are the final authority on that. What is in our hand is to try and convey, give them information to the best of our knowledge and ability, so that tomorrow, when you go back home and sleep, your conscience is clear that you tried. Trying is in our hands. You cannot change what happens in the cosmos. It will move on its own rhythm. People will decide based on what is right for them, what they believe is okay for them. That is fine. That is absolutely fine. You did what was in your hands and let it go.
Thank you, sir. Thank you so much.
Also, also.
Sir, I have two questions, Dr. Ashok and then Dr. Ritesh. So Dr. Ashok, can you narrate your question first, and after that Dr. Ritesh, and then we will close the session.
Hi, good evening.
Good evening.
My question is that sometimes the bystanders that come with the patient changes. It might be the same bystander that comes for a couple of weeks, and then a totally new person comes, and that person may have absolutely no idea what's going on. What is the diagnosis of the patient, prognosis, what we have explained. Sometimes we have already told the patient, and the patient finds it uncomfortable, trying to explain it all to the new guy. How should we handle that? Should we suggest that one person should be always there, at least available by phone, or should we ask kind of like a handover system in which one bystander can at least, if not keep the new bystander up to speed, but at least give the basics about the condition of the patient and the client?
Yeah, this is quite a common problem, and perhaps we can only try to find out solutions to each situation. What you said, that trying to see whether the same bystander stays put is something that may not be possible all the time. Sometimes it is possible. Sometimes you have logistical problems that the same people cannot stay, and sometimes you may have to up to date the knowledge of the new person, and it can be quite tiring, sometimes frustrating, because the new person will come and ask all kinds of questions over which we would have already spent a lot of time. And that is why I prefer to have a family conference beforehand. Because of COVID, the sitting in the same room and having 10-15 people together is no longer possible. However, in the hospital where I am, we have a telemedicine facility, and I've had a couple of occasions where we have had a family conference where two children are in US, one person is in the Middle East, and another child is in Bangalore, and over telemedicine we have connected and had a discussion so that everybody is kind of on the same page. Now I realize that the technology may be
Hello.
available in most places, may not be available in
ഞാൻ
some
തിരക്കാണ്
places.
ഒരു 10 മിനിറ്റ് ഞാൻ വിളിക്കാം.
Yeah, so it is depending on what we have in our hand. We can try to see whether we can get all caregivers on the same page. Sometimes it is just not possible. Now then, what can we do about it? So please understand, if you are the chief oncologist of your institution. The onus of communicating cannot be only yours. You Communication is a team sport. You have to empower every person in your team with communication skills. I would say even from the security guard who mans the gate of your institution all the way up to the executive director of your institution, everybody we should all undergo a structured training program in communication skills. It will help because communication cannot be one man's burden. It is a team sport. We all need to pitch in together, and the importance of everybody having been trained in communication is that we will be precise in the messaging. We will not be giving conflicting messages, different people giving different messages to the patient or the family, which creates a lot of confusion. So we have to use multiple ways of dealing with the problem you brought about. I hope some of the suggestions would work for you.
Dr. Ritesh, last question.
Yeah, hi, good evening.
Good
It
evening.
was an excellent question, sir, in a very simple language, and I learned a lot today. So my question is, yeah, sir, my question is, sir, sometimes we get terminally ill patients, and the attendants would request for some supportive measures like, why don't you start oxygen? Why don't you shift the patient to ICU? So how to deal with this kind of situation?
Right. So again, end of life care counseling is again another domain. Of course, I did not touch upon that during this presentation because the mandate was to talk about communicating bad news, a little bit of collusion, a little bit of anger. So there is another session called end of life care counseling where we talk about the pros and cons. For example, in a very short answer, when I talk to people, I tell them that when it comes to ICU, sometimes if the heart stops, then you have to pump the chest, and if you do it right, maybe one or two ribs may be broken. Sometimes the breathing stops, and you have to put a tube through the mouth and connect to a ventilator or a machine which will breathe for the patient. All of this involves putting the person to a lot of medical torture. But then we can justify it because we are trying to save a life. And then the patient is in the ICU, the family is outside, and the family is experiencing so much of emotional trauma, emotional torture, psychological torture. We can justify that also because we are trying to save a life. And then a lot of money has to be spent because saving life involves a lot of money. So a lot of financial torture is put on the family. That is also justified because here we are trying to save a life in the ICU. However, if somebody has a disease which is incurable, which is progressed to an advanced stage, and we know that the person's life cannot be saved, how do you justify torturing that person physically, torturing the family emotionally, and torturing them financially? It just cannot be justified. It is unethical. It is immoral. You should protect your loved one from this kind of situation. You should go and tell the doctor, doctor, I understood everything. I don't want him into the ICU. Just admit him and give him some care in the room. And I will sign anywhere you want me to sign. Please don't put him in the ICU. I'll tell the family member, you go and tell the doctor this way. So in this way, I kind of make them understand, and I coach them, guide them, and coach them as to how to go and approach the healthcare system when they seek end of life care for their terminally ill patients, how to prevent them going into the ICU, what to tell the doctors in the emergency room, etc., etc. Most of the time it works.
So that concludes
Thank
our
you, sir.
session. Thank you. Thank you, Biju Raghavan sir. Thank you for your time.
Most welcome. Thank you for the opportunity.
Yeah, you made it very simple, but actually it's very complex. It's really demands a lot of time, effort, and training and practice.
Dr. Cheriantampi is saying hi. So nice to see you over here.
Okay.
It's been a long time.
All right. We will catch back again, return next week for session number